it's my pleasure to present Dr. Victoria Persky. Um, uh, Dr. Persky is a professor of epidemiology and biostatistics at the School of Public Health at UIC. During her more than 40 years at UIC, she's also worked as an internist at the neighborhood Erie Family Health Center on the west side of Chicago. Her research focuses on asthma and health effects of exposures to persistent organic pollutants, with more than 135 peer-reviewed publications and 64 grants. She was the co-founder and is currently a board member of Mobile Care Chicago, which delivers asthma and dental care to underserved communities. She is also co-chair of the data committee and a member of the executive committee of the IDPH Illinois Asthma Program. Dr. Persky is a past member of the Chicago Asthma Consortium, Illinois Board of Health, and the US EPA Science Advisory Board's Chemical Assessment Advisory Committee, as well as numerous other national advisory and NIH grant review committees. So Dr. Persky, I'll pass it over to you. Thank you so much for joining us here.
The reason that Dr. Erdal and I switched the presentation order was that I'm talking about the general data relating asthma to ambient air pollution and mostly past data. And she's going to move ahead into the current technology and how we're measuring it. So we were asked to look at the respiratory effects of exposure to ambient air pollution and measurements of that. And again, as I said, I think it's a nice segue from the social determinants of disease, because I don't think many people now question what Dr. Boleman was discussing, but I think the issue that Dr. Erdal and I are addressing is, can ambient air pollution be one of the mechanisms by which social determinants are activated? Just as a very quick summary, ambient air pollution comes from many different sources. And the proportion of those sources vary by pollutant. I'd just like to point out one or two from the slide. SO2, which has the long dark bar, is generally thought to be more related to the stationary fuel combustion, whereas particulates and fine particulates, as measured by 2.5 microgram per meter cube, is more varied. And NO2 has relatively more association with the red bar, which is a mobile sources of pollution. So looking at each of these individually and together has merit. Okay, these days, and it's an old slide but still holds, the highest levels of pollution internationally are in countries that are developing, and in particular India and China, with as much as tenfold differences between our urban exposures here and those seen in China. But even within Europe, there are differences in exposures to fine particulates. Again, it's an old slide, but I think it's good visually, with higher exposures seen in Eastern Europe than in the more Western part. And within Europe, around Europe, there are exposures that are higher than even the current EU standards. These are our current air quality standards. And so many studies are focused on these because they are included in the national air monitoring systems. And I want to point out one or two numbers because we'll come back to them. In particular, the fine particulates, PM 2.5, our current standard in the United States for annual mean is 12 micrograms per meter cubed. So remember the number 12. And the 24-hour standard is 35 microgram per meter cubed, with ozone around 70 parts per billion. Again, these are more frequently measured, so those are the numbers that I'm going to come back to.
Dr. Erdal, I'm going to I'm sorry, Dr. Persky, I'm going to interrupt for just a second. We are seeing your slides, but they're not in the presentation mode.
Oh, good point.
Yeah.
Thanks for reminding me. Yes.
Sure.
Sorry about that. There we go. Is that
Yep,
better?
looks great. Yes, thank you.
I'm so glad you told me. I missed it. Okay, because to see the numbers, you need a bigger mode. Okay, 2 years ago, the WHO changed its recommendations, and I'd like you to look at the top two. Right now, WHO is recommending an annual level of 5 as opposed to our 12 microgram per meter cubed, and a 24-hour measurement of 15 as opposed to our 35. So we are behind the WHO, and we are considerably behind. Throughout the world and within the United States, ambient air pollution is highest in low-income minority populations. So globally, it's thought that 4.4 million deaths occur each year from outdoor ambient pollution, with 7 billion people in areas at levels above the WHO standard. And low-income populations having higher exposure and higher sensitivity to that exposure. This was an air toxics estimate from quite a while ago, estimating, and this is an estimate, we have better data now, that African Americans were more exposed than Caucasians. But more recent estimates here for different pollutants, this one shows NO2, which remember I said was more often related to traffic than some of the others, having higher exposure levels in the blue and the green than Caucasians, who had higher rates of lower exposures in the orange. Internationally as well, fine particulates have higher exposure in the lower income areas in Eastern Europe. And a very recent genetic study out of the UK Biobank of almost 500,000 people looked at genetic African and ethnic genetic ancestry in relation to exposure, and noted that African Americans and Hispanics had higher exposure than other groups. But in addition to having higher exposure, as I said, there are sensitive populations. So as we know, children, aged, are generally more sensitive to any exposure. But in particularly related here, low-income people and those with comorbid conditions, which is also related to being low income, are more sensitive to the lower levels of exposure to which they are subjected. Okay, so there are a variety of kinds of studies that have looked at respiratory effects. There's mortality, total and respiratory. There's symptoms, there's lung function, and as I said, there's recent data on incidence of the disease. In terms of mortality, there's a number of studies. I don't expect you to read each of these in this slide, but many of these date back many decades, showing increased all-cause and cardiopulmonary and respiratory deaths in relation to fine particulates. But towards the top, there is a more recent study from Denmark, which shows with a 5 microgram per meter cubed, which is half of what they previously had estimated with their percentages, there was 11% increase in respiratory deaths. This is a study published a year ago. And it's currently estimated in Europe that life expectancy is reduced by 2.2 years because of ambient air pollution. Okay, within the United States, deaths are higher among African Americans. We've known this for a while. This is not new data. Within Chicago, this is some old data from our group, and it's actually this. It goes back to the 90s. The earlier data we did publish. This is not published. The earlier data from the 80s was almost identical, showing increased mortality rates by geographic region in Chicago being higher on the south and the west side. Hospitalizations and ER visits are similarly higher on the south and west side. And they've been measured, the morbidity is measured not just by hospitalizations and ER visits, but also by panel studies that is cohort studies with repeated measurements, a few experimental studies. People have looked in the past for a while at interactions between the exposures and genotypes. But what is new is, to some extent, is that the effects are seen, as I said, below the current standard. And that's quite consistent now. And what's new is that ozone and particulates are related to incidence, the development of the disease. Again, this is an old study, but I really like it because it then incorporates an intervention trial. This is from Isabel Romeo in Mexico City looking at ozone. The levels of ozone were and are higher than here. This shows the relationship with a 50 part per billion increase, so that's quite a big difference in 1990. But she went on and showed an interaction effect with the GST genotype, which has been related to oxidative stress, which in turn has been related to asthma, and followed it with an intervention study stratifying by that genotype and showing an inverse relationship with ozone, with pulmonary function and ozone, and those that received reversed it with an antioxidant supplementation. Okay, so this is ER visits, asthma ER visits by sex, age, race, and ethnicity and poverty, more recent data. This is from the MMWR, and again shows that there's higher ER visits in those who are of minority population and of less income. And the good news is that it has been decreasing nationally and here in Illinois. This is again more recent data of hospitalizations in Chicago that mirrors our older data on deaths, with higher hospitalization rates in children on the south and west side of the city. This is from IDPH's asthma program. So one of the questions that came up many decades ago when I was looking at our data and other people's data is, could one explain the morbidity and mortality by prevalence? And can we use that data to see if we can actually prevent the disease? And I think the answer is that we do not have enough data yet to say that we can prevent the disease, although we have more data than we did then. And we do have data now that we did not have then, that air pollution may be contributing. But just to show some of the data that existed, our Chicago asthma prevalence study and a random sample of public and Catholic schools that ended up as one of the studies in the International Study of Asthma and Allergy in Childhood, looked at the relationship of prevalence to poverty census tracts in the overall group. We were not allowed to look at race and ethnicity. This was many years ago with an administration in the public schools that did not allow that. But we were able to look at least in the census tract areas, and we did find not quite twice the rate of wheezing of asthma diagnosis in the lower income neighborhoods. But within the Catholic schools, where this is not published data, but I think shows one of the conclusions that I had then and I still have, which is that it did not seem to be an overwhelming difference in prevalence of Blacks and whites, with much higher rates in Puerto Rican children and lower rates in children of Mexican ancestry. And this was, a little control for SES because it was Catholic schools. This was subsequently Ruchi Gupta looked at community crime and asthma prevalence in Chicago with an excellent prevalence study, and again showed the prevalence rates higher on the south and the west side, similar to what we'd seen, what had been seen for hospitalizations and deaths. But the direct association with crime, again, highlighted the possible relationship with stress, violence that, Dr. Volerman was talking about, and asthma. But again, what was thought before all of this was that stress and violence exacerbated the disease. And what we're seeing now, and I think, is that possibly it affects the development of the disease. So the ratio, I believe, although there is some controversy on this, that racial and ethnic differences in prevalence exist, but they're lower than the differences in morbidity and mortality. So the subject of the rest of my talk and Dr. Erdal's talk is how much can ambient air pollution be contributing to the differences in morbidity and mortality. Okay, so the role of ambient air pollution. Okay, what we're seeing in this slide and another few slides is that the relationship of particulates and all-cause mortality holds way below the current threshold of 12 microgram per meter cubed for the annual standard. So if you can see here, it holds way below 12 and even below 5. This is for particulates, and then we see the same thing for ozone. So our current standards are not adequate. What's the corollary of that? It means that when we're advocating for community groups and when we're looking at policy, we cannot accept the pushback from those who are polluting, saying, well, it's safe below the current standards. This is a part of a series of studies we did in East Moline back after the 1993 Mississippi flood. We did an in-depth study of residents of Campbell's Island, which is an island within the Mississippi, where the ozone levels, the mean level was 20 parts per billion. So it's much lower than here in Chicago. And Mary Ross, who was a graduate student with us then and has subsequently gone on to an illustrious career at EPA, looked at the relationship with peak flow and ozone levels at this low level and found an inverse association in a panel study of, I think, 50-something children. That's ozone. Now with particulates, there's a very similar story. Data consistently relates exposure to particulates, especially fine particulates, to morbidity and mortality. What's recent is that there's also an increasing data saying that in utero, early and adult exposure are all associated with development of the disease. When we're looking at morbidity, it's usually about a 1 to 2 day lag. And there is continuing to be evidence for gene-environment interaction. This is just looking at wheezing in infancy by proximity to traffic, and with stronger relationship in African Americans. And then this is a case crossover design where they looked at exposure on the day of the hospitalization in relation to the exposures in a certain time period before and after. And this is the Medicaid population, so it's a lower income population, and found an increase in hospitalizations per microgram per meter cubed with a lag of about 0 to 6 days, and it's only in people. They only looked at people below the current standards. So this was a 1 day standard of 35. Remember the number 35 as a daily standard. And at that low level, they saw a dose response that was pretty impressive in terms of hospitalizations. And then in terms of incidence, I think the oldest study I know is one by Rob McConnell back in LA about 20 years ago, looking at children living in high ozone areas around LA, low ozone areas, and found a higher incidence of asthma in those children living in high ozone areas. The recent data, though, is just really burgeoning. I mean, this is the UK Biobank again of 300,000 adults aged 37 to 73 with a mean follow-up of 12 years, and NO2 showing an increase at levels below what we might have noted. And remember the number 12 again, this is the same cohort looking at PM 2.5 with a strong association below the level of 12. And again, it's a cohort of 300,000 people followed. So that's pretty big. Again, showing that we need to revisit our current standards. And then finally, Denmark, they have a centralized database of 1 million children born between 1998 and 2016, followed an average of 8.8 years, within whom 6% developed asthma. And they found an association with incidence of asthma and PM 2.5. And looking at the possible reasons for these associations, they looked at nasal mucosa and possible immune mediators. What we don't know, and I think I think Dr. Erdal and some of the her really wonderful new projects hopefully will address, and others are, what on these particulates? What are the key elements on these particulates that may be responsible? Are they endotoxins, metals, PAHs, dust, bacteria, fungi? We don't know. All we know is that a certain diameter relates to morbidity, mortality, and incidence. As a lead-in to Dr. Erdal, I just want to mention some work that we've done in Southeast Chicago as an example of the importance of community involvement, both in terms of hypothesis generation and testing. So, as most of you probably know, Southeast Chicago is an area that was heavily industrialized. It was a center of the steel industry. There were legacy pollutants, but there were also ongoing pollutants. And the community has been concerned for quite a while about it. The biggest concern for a while was manganese. The Washington High School EPA monitoring site picked up a few years ago that manganese levels were higher down there than from other sites. And the question is why? And I'll just quickly outline one or two papers that we did, and then lead into, and a couple other issues that we've been dealing with, and then lead into Dr. Erdal's part of the talk. We first did a quick paper looking at the N. Haynes data on pulmonary function in metals. But then to be more responsive to the community, we did and published a paper with Mobile Care and with Dr. Papalato, et cetera, from Mobile Care, a pilot study of the toenail metals in the children being cared for by Mobile Care and the lung function in those with asthma. As a follow-up to that, at the community's urging, we are now finishing, we're just reporting the results on toenail metals and the soil metal measurements taken by EPA and CDPH. And I think Dr. Erdal is going to touch upon general iron and metal recycling. If she doesn't, we'll come back to it later. And then again, we developed an app to be used both on stationary and computers and mobile devices, so the community can look at and record concerns. So if they see dust in the air, they record it with the place and the time. Okay, just as a quick lead-in, the metals in Southeast Chicago, as I said, they were a legacy from the steel industry. The impetus for this came from the community concerned about manganese levels. This is the area of the city. Just prior to that, the community was concerned about SH Bell, an industry that uses metals, and CDPH and EPA measured the soil and found higher levels around SH Bell. This was in 2017 to 18. We looked at lung function with Mobile Care on the toenail metals in the children with asthma, and as you can see, the Dr. Papalato, Matt, then others were involved, and Jessica Madrigal was our student who published this. This was published 2 years ago. The inclusion criteria was 75 children, school children served by mobile care in Southeast Chicago and Little Village. And a quick summary of the results was that measurements of several metals were higher in Southeast Chicago: cadmium, cobalt, iron, manganese, and vanadium. Copper, manganese, and vanadium were negatively associated with measures of lung function, and nickel and copper appeared to be associated with more uncontrolled asthma. Again, this was a very small study, which we'd like to see replicated in a bigger and better way at some point. But what came out of this and all this previous work, and again, leading into Dr. Erdal's talk, was the huge importance of ongoing surveillance. The current EPA monitoring does not have a fine grid. I think Dr. Erdal will be talking about the implosion of the Crawford plant and how we wished we'd had more local monitors being maintained around there at the time. The closest monitor was 7 miles away, which was very frustrating. Over the many decades, I've heard community members tell me, "Oh, I couldn't breathe last night. I don't understand why." And we did not have a system that allowed for measuring that. You know, was there something that happened in a local industry? Was there something in the highway that created problems? And there wasn't any data. It's very important that we listen to the community members and what they're concerned about, because they know. And Dr. Erdal is going to talk about the local monitoring systems now and what we see developing in the future. I think it's really critical. I think there have been efforts by the city to do this, and it hasn't quite worked yet. You know, they tried to put monitors on connected to electricity and poles, and they just didn't quite work as far back as the Emanuel administration. So I really think, Dr. Erdal is exactly where you need to be right now. Where's the technology? How are we applying it? And how are we involving community groups so we have better data? So finally, the effects of ambient air pollution are significant at levels way below our current standards. There's stronger and low-income populations who are more sensitive to the effect of ambient air pollution. The dose responses vary by population and pollutant, and we desperately need more data on constituents, on mixed exposures, and very local monitoring systems. I think I did it in 20 minutes, maybe not. If I didn't, I really apologize, Serap.
Well, thank you, Dr. Persky. And actually, this is about the halfway point of the conference. So I think we'll do just a very brief 3 to 5 minute break. Sorry to introduce a cliffhanger, but we'll once we come back, then we'll jump right back in with Dr. Erdal's presentation. And we'll do a Q&A after that with both Dr. Persky and Dr. Erdal. Dr. Serap Erdal is an associate professor at the Division of Environmental and Occupational Health Sciences at the University of Illinois Chicago School of Public Health. Through her positions in academia, government, and industry, Dr. Erdal has performed exposure and health risk assessments for Fortune 500 companies and government entities, like the U.S. Department of Defense and the Department of Energy. Her specialty areas are human exposure and health risk assessment, and community-based participatory research. She has an active research program focusing on environmental justice in partnership with local community organizations in the Chicago metropolitan area, with funding from CDC, US EPA, NIEHS, and NIST. So with that, Dr. Erdal, I'll turn it over to you.
Thank you so much, Matt. First of all, I'd like to thank Chicago Asthma Consortium for inviting me. And today I'm going to take all of you through a journey of the work that we have done in Chicago in partnership with our community organizations, building on what Dr. Persky summarized in terms of health effects of air pollution and interface with asthma. I will primarily focus on, after describing some of the work that we've done, what are the lessons learned for future community-driven efforts for exposure assessment and air quality monitoring and control and management. And then what are the plans and projects that built on local knowledge for development of enhanced and real-time community public-owned air monitoring infrastructure in Chicago to guide local policy, permitting and zoning decisions, as well as to support health effects research, including, of course, that includes asthma. I'll start with, because we're focusing on determinants of health and interface with asthma, I'd like to start with the types of studies that have been done in our area that culminated in mapping and description of cumulative burden faced by our communities in the Chicago area. The first effort was by NRDC back in 2007. They used EPA's environmental justice screening and mapping tool called EJ Screen, using 11 environmental variables and six socioeconomic variables. They estimated cumulative burden faced by census tracts across Chicago. As you can see here, as Dr. Persky described, the neighborhoods in the western and southeastern part of Chicago face higher environmental pollution and cumulative burden, health burden. The same efforts have been, EPA has been constantly updating EJ Screen. Now they added more variables related to climate change impacts on communities. Here you're seeing the latest data for PM 2.5. These are model data. Again, it shows the a heavy burden faced on Western, Southeastern communities. Then the next slide, this doesn't just include PM 2.5 concentrations, but also it includes the toxicity of the chemicals that contribute to burden. So it is a risk measure rather than concentration measure. Here, we're not just looking at PM 2.5, by the way, we're looking at all of the chemicals listed and regulated under toxic release inventory. And again, we're seeing the same spatial outcome of Western and Southeastern communities with the higher burden. And I should also point out that when we look at the percentiles of data, we're looking at not just the distribution doesn't just cover the range for our region. This is the 95th or 100th percentile of the national across the US. If you look at the percentile distribution across all census tracts across the US, we're in 95th, 100th percentile in these red areas. And I think that should give us, all of us, a clear understanding of the burden that our communities are facing. And City of Chicago created an Air Quality and Health Index in 2020. And this report is available on their site, and they concluded that their map also shows that the areas of greatest concern are primarily located on south and west sides of the city. This is just brand new, released almost a month ago. City of Chicago engaged in cumulative impact assessment work in partnership with community organizations in Chicago, and they created this cumulative impact assessment map. And I contributed to the development of this map is a technical consultant, and we're seeing, and actually this map is going to form the basis of cities' first, hopefully, ordinance, environmental justice ordinance that will guide all of the permitting, zoning, and planning, city planning decisions for the city of Chicago. And all of these maps, when we look at them, they pretty much also align with where the industrial corridors in Chicago, and we have to keep that in mind also. And given all this picture, we've been working primarily with Chicago Environmental Justice Network partners, 5 organizations on the west side and southeast side. They formed an umbrella organization, and these organizations on the west side, Little Village Environmental Justice Organization, and on the south side, Blacks in Green. Actually, Neighbors for Environmental Justice is also on the west side. PCR, People for Community Recovery, and CTF, Southeast Environmental Task Force, they are on the southeast side, along with Blacks in Green. And these organizations are national leaders in environmental justice movement, and I think we need to highlight that too. The first study that involved true community participatory effort was an EPA grant that we obtained back in 2016-17, shared action, community empowerment through low-cost air monitoring. When Dr. Griswold at KSU, at that time, currently in Memphis University, was the PI of this project. And you're seeing the same community, some of the same community organizations as partners. Here, really, this was a feasibility study to explore and evaluate the ability of the residents in overburdened communities to be able to conduct air monitoring using low-cost sensors and effectively communicate, interpret the data so that they can engage in community empowerment and advocacy activities. Here you're seeing a community engagement session that we performed. You're seeing the prevailing wind direction, and we generated maps to empower the community on a number of important indicators such as PM 2.5 concentration, diesel PM concentration, the traffic-related variables, socioeconomic variables. After sharing all that quantitative data, we engaged in a more qualitative discussion on their community lived-in experiences for us to be able to develop a community-driven air monitoring network. And this is Little Village's map, and the dots that you're seeing is the community's input into where we should be placing our sensors. And then the next step was I trained the community organization staff on air monitoring using sensors. Here you're seeing a subject with 2 different sensors, 2 air beam sensors that measure PM 2.5 in the breathing zone, and 2 purple color sensors called Harrier sensors. They are designed by University of Colorado to measure gaseous pollutants in the breathing zone, such as carbon monoxide and nitrogen dioxide. So we used the train-the-trainer approach. I trained the community organizers, and the community organizers trained residents, and we shadowed the sampling runs to assess the performance of the citizens to use these sensors effectively and correctly, and during 20% of the total sampling runs. And we also had training sessions on data cleaning, data management, and data analysis. And this is our feasibility assessment tool in terms of assessing the compliance of the residents to adhere to study protocols. And here you're seeing whether one indicator that we assess was whether the samplers were correctly placed in the breeding zone. And most of the, as you can see from the data, there was high compliance. And then this is another indicator. We assessed whether there was the level of compliance with the general sampling procedures. Again, there was high compliance. In addition, we placed all of the 5 sensors that we used in the study. You're seeing the PA 14, PA6, PA9 here. Those are purple air sensors used to measure PM 2.5. And then you're seeing here air beam 1, 2, 3, the black sensors. Those also measure fine particulate matter in air, but they are mobile monitors, meaning that you attach them in the breathing zone. On the other hand, purple air sensors are stationary sensors. You place them at a fixed location in the community. And then we also use Met1's PM 2.5 and PM10 neighborhood monitor. They are more expensive instruments. So you're seeing that at the top of the slides. Furthermore, we used air qual sensor for measurement of NO2, the top one, and the bottom one is the measurement of ozone. What you're seeing in the background is all of the large EPA's federal reference monitors and federal equivalent monitors. We placed all of the sensors at US EPA's Northbrook is air monitoring station, which is a super site in our region because it houses all the advanced instrumentation at one location. And so empowered with this study, and we did this so that we can compare the performance of these sensors against the gold standard, the data generated by the gold standard FRM, EPA's FRM and FEM instruments, so that we can convert our data, sensor data, to FRM, FEM equivalent data, because that data has public health significance. Sensor data doesn't. It allows us to give a representative I should say relative concentrations of ambient air concentrations, but those data have no public health significance. And the reason for that is because we use the FRM, FEM data to assess compliance with the National Ambient Air Quality Standards. Those are health-based standards developed from epidemiological studies, as Dr. Persky described in her slides. The next study was a CAC NIH-funded pilot grant. There was an air pollution episode in Little Village in the midst of the pandemic on April 11, 2020. And we wanted to find out the impact of that air pollution episode on the community. And also, we wanted to overall also understand the spatial distribution of fine particulate matter in Chicago. This is, you're seeing what went wrong here. The city permitted a private company to demolish a former smokestack of a former coal gasification plant in Little Village. And the private contractor didn't follow the protocol, which resulted in Little Village being blanketed by this heavy plume. We looked at the data from all angles. On the day of the demolition, this event, air pollution event, the winds were coming from southwest, which is a typical wind pattern in Chicago. And there were 3 PM purple air stations operating in Little Village. And Little Village is primarily a Latinx Hispanic community. And you're seeing here from April 1 to 30, PM 2.5 24 average PM 2.5 concentrations. The yellow arrow shows the day that the demolition this air pollution episode occurred, and we didn't see based on the data impact of this disproportionate impact of this air pollution event as compared to the other days. So we went further. We looked at 1 minute averages from the purple air stations. The earlier one also from the purple air stations, and we still didn't see an impact because there were higher concentrations before and after of this demolition event. And we looked at PM10 as well, and that was also didn't give us a kind of a footprint for this demolition event. And this is partly an artifact of the fact that in Chicago, in Cook County, we have 10 EPA federal reference monitor sites operating and only 2 federal equivalent monitors operating. The difference between the two is FEMs give us 1 hour average concentrations, FRMs give us 24-hour average concentrations. For a health effects such as asthma, FEMs are better tools that we need, but you're seeing that we don't have good spatial coverage, particularly in environmental justice communities. In addition, what we found out is that purple air sensors, those 2, 3 sensors in the community, one a little bit beyond it, they were not situated correctly in the path of this plume to allow us to gather relevant data to be able to show the impact of this major air pollution event. So the siting of the sensors are critically important. And purple air sensors are being utilized by different organizations and citizens to collect ambient air quality data. In 2020, we had 38 of them were operating in Cook County, but everyone is putting them at different locations. There's no siting criteria that is followed. Unlike the EPA's FRMs and FEMs, they need to meet Federal Clean Air Act guidelines, so there's strict siting criteria behind them, and this is all contributing to this substandard picture. And here you're seeing the data, both EPA monitor data and purple air data on one single map for 2019 and 2020. What we're seeing here most importantly is there are significant spatial variations even in the same neighborhoods in terms of exposure levels. So that highlights the fact that we need to have hyperlocal real-time measurement of ambient air pollutants to be able to understand exposure dynamics at the community level. And then what you don't see here is in 2021, Microsoft came to our city and established a network using their sensors, Eclipse sensors. They placed 100+ sensors across Chicago at bus stops, and it wasn't working for them. A year later, the Madeline Depp approached me for funding a study based on what I wanted to do. And I said, we truly need a community-driven air quality network plan that is co-developed with our community partners. And that work involved, we then brought CNT on board for data visualization effort. Again, this work was in partnership with Alvejo. And this is what you're seeing here, my scope of work, building this network on all the quantitative data from publicly available sources in terms of concentrations, emissions, traffic, and warehouse locations, and all of the community asset and threat data, along with socioeconomic data, and in superimposing that with qualitative data in terms of community lived in experience in air quality, because the publicly available data is sometimes outdated. Sometimes we don't have data at the locations we need. This is why we need to supplement quantitative data with qualitative data to get a more complete picture of the burden faced by our communities. So those, I'm going to skip. How am I doing in terms of time? Okay, I'm almost out of time. So these are the quantitative data that you're seeing in terms of emissions, traffic, weather, socioeconomic, community asset data. This is what we put together that shows the PM2.5 concentrations measured. These are the 95th upper confidence limit on the mean concentrations, which are the proper metric for the exposure point concentration. It includes all the data from EPA stations, Purple Air stations, and Microsoft's Eclipse stations. And this is this is a case study on what not to do. When Microsoft placed the sensors, they chose the bus sensors. What that resulted in is the sensors were heavily impacted by the traffic, but particularly bus traffic, and because they were in such close proximity to the traffic sources. So they were really sensors that measured the impact of mobile sources as opposed to community exposures. In addition, Black and brown communities have less public transportation. So the areas with higher bus service had higher concentrations as compared to areas that don't have as much bus service, had lower concentrations. And you're seeing, for example, Southeast side, because they have less bus service, they had less coverage of the sensors. Dr. Persky talked about the EnviroReport app tool that she took she's the architect of this tool in terms of citizen interaction with air quality. And we're still in the midst of further developing this tool towards streaming air quality data so that we can analyze and summarize the data and share the data with our communities. Here, what I'd like to summarize is that, yes, we can do these types of studies, but because these devices have become available and the citizens are using, there is this misperception that we can place them anywhere. And but they have to we have to follow the same protocol that we do for the EPA's FRMs and FEMs. There is quite a bit of technical detail and knowledge involved in utilizing them properly to be able to get meaningful data. And the citing criteria is not followed at all. It is really important when we place the monitors, we place them at the height in 5 feet, which is the average US adult male-female breathing zone height, so that the measurements mimic human exposures at the community level. And anytime we're using these tools that are not laboratory tested, field tested, we have to place them next to FRMs and FEMs so that we can understand their performance and we can interpret the data in terms of their public health significance. There's significant training that needs to be done for the community members to be able to use and interact with these devices. And but most importantly, I think that in the US, we don't have public health surveillance system. I feel that we're missing the boat. And with the availability of these devices, it's an opportunity to develop an exposure surveillance, national exposure surveillance program. Now the technology is enabling us to do that. And again, we have a very fragmented approach to this, and in the absence of leadership from US EPA, NIHS, and other national organizations. And lastly, I want to show you these tools are being utilized in a very effective manner for asthma management, and in order to develop an individually tailored understanding of each child's asthma. Here is a study in UCLA called Biomedical Real-Time Health Evaluation Breathe Study. They used a number of sensors: GPS, spirometry, inhaler use, activity monitoring, black carbon sensor, particulate matter sensor, ozone and VOC sensor, and in addition, the users can enter their self-reported measures and asthma symptoms. All of these data go to interface with a smartwatch or smartphone, and accompanied by electronic health record data goes to the server of UCLA, and then the data are analyzed by statisticians, epidemiologists, and environmental health scientists, and exposure summary measures are created, and then this information is displayed in a dashboard shared with healthcare providers and child and parent caregivers and the scientists, to allow more real-time management of asthma. And these things are becoming a reality, and our studies are showing that they are feasible. And it's just that we need to be more intentional about using these tools to really advance the management of health effects in a more timely manner. Thank you so much. Oh, lastly, I think that I wanted to share we secured a number of grants. One of them is we secured, I wrote a grant to the Congressional Directed Spending Program, and this is an earmark from Congress to establish a sensor-based network in Chicago. We're getting ready to launch that study. This is a 2 million study, and we're working with the city of Chicago as well, because they secured some federal funding, so that and this work will primarily concentrate on establishing a network in Chicago's EJ communities. We had got an EPA grant to assess the air quality and health impacts of the electrification, and when the fleet turns over to electric vehicles, what would the air quality and health impacts would be. We're also recipient of the US EPA 17 environmental justice training assistance centers, and Blacks in Green is the lead organization, and UIC is providing technical support in environmental and health issues to communities across Region 5. And furthermore, we have an NIHS CAC pilot grant to establish an environmental justice scholar program in Chicago, again in partnership with the CJ and partner organizations. Thank you.
Okay. Thank you so much, Dr. Erdal. And all right, so we'll move over to the joint question and answer with Dr. Erdal and Dr. Persky. So anyone who would like to ask a question, you can just throw it into the chat, and I'll make sure to get to those. I think I'm really interested in starting with just a very basic question, which is that, when we're talking about asthma and its relationship to air quality, I wonder if you could just give a quick answer on, you know, with what you're seeing, is it that air quality issues and particularly like industrial pollution could increase asthma prevalence, could increase asthma severity, or it could make medications less effective in treating asthma? And
All of the above, I would say.
okay,
Not an expert on how effective each medication is, but I think the data supports mortality, morbidity, and incidence. And incidence then affects prevalence.
thank you. And when we're talking about like monitoring air quality, like what are some of the sort of like bio measures that you're pairing with the air quality measures to really get an understanding of like how air quality is affecting lung function?
Very good question. We measure things in we measured toenails in the study we did with you because they were easier to get, but we don't have standards for toenails. But we didn't want to take blood from kids unnecessarily. We probably have somewhat better standards for some of this, like metals for blood. Historically, blood, hair, urine, toenails. Those are the kinds of biologic measurements where they were used. And each has advantages and disadvantages. Hair tends to have disadvantages that, the shampoo, et cetera, can change whatever you say. But I think it's important to get both environmental and biologic measures, if that's your question.
It is, and I think I'll come back to that in a little bit, but I want to get to Eric's question here.
Yeah.
Where can we find out more information about what sounded like an upcoming environmental justice and zoning ordinance in Chicago? And maybe Dr. Erdal, I'll
That's a
point that to you.
Yeah, I just sent the link to the City of Chicago website, and the report is not, the technical report has not been published yet. The map that I showed you, but you'll see the map there, and you'll see some of the preliminary reports. But the ordinance language has not been released yet, but the plan is to weave that map and write the ordinance around the map.
And if I could ask a follow-up question, so like what would be the like best case scenario of the implementation of the ordinance?
The city's plan is, we don't yet know the language behind the ordinance, but their plan is to provide funding to EJ communities, but also change the way that the city operates in terms of its zoning, its permitting, its city planning, transportation planning, so that the burdens on the communities based on this cumulative burden is considered in the decision making. In terms of how that's going to be considered, it's not that clear in terms of what the process will be, but this is the vision that they are articulating. Then I'm curious too, but our community partners co-chaired this effort along with the City of Chicago staff, CDPH staff. And so I think that we're all curious to see how this will evolve.
And Dr. Erdal, I know you have to go in a couple minutes, but I also just wanted to ask, if there is an ordinance, or has there been any talk about having new industrial or manufacturing interests sort of present a remediation plan along with the sort of like results of a burden study, or even have some people who are heavy emitters right now have an opportunity to present some sort of like remediation plan for what they're doing?
I think that we don't know. The map that I showed you, it includes 28 different variables, and the asthma is one of them under sensitive populations component. There were 4 components, environmental exposure component. There were 8 variables under that. Another component was environmental conditions, 7 variables under that. Sensitive populations component, it included asthma, but it had other 5 different variables. And then there were 7 SES factors. And those facilities have permits, obviously, air quality permits. Some of them are grandfathered. So I think this is more for the way forward rather than retrospective. And when those sources change their operations, then their permit can be opened up and further conditions could be placed on those permits. But I think that this is going to be based, this will be, City of Chicago will be a national leader on this if they are able to pass this ordinance, EJ ordinance. So how it's going to impact the already permitted facilities remains to be seen.
Yeah. And again, I know that you have to leave, but I want to ask just one more question out of curiosity. I don't know how you'll know the answer, but the the industrial corridors in the city have been around for a really long time, and part of what perpetuates that sort of concentration of heavy industry in those areas of the city is due to the widening of the roads, the lack of viaducts, like the general ability to get in and out of places quickly with very large vehicles. And I think that's going to be a really difficult issue for the city to overcome because, there's the infrastructure in the rest of the city has already been built up and it's very difficult to like widen roads and stuff like that. Has there been any discussion that you've heard of like how you can start to undo some of those sort of historic factors that make certain areas heavily invested in from industry, and also like where the air quality is very clearly affecting people's ability to breathe?
I am not as much involved with the transportation issues and planning, but one of the major, more recent factors is these warehouses and the trucks carrying goods to and from these warehouses, and they are all diesel engine powered vehicles. They contribute heavily to diesel PM burden, which is more recent exposure burden, in addition to all the other air pollution burden. So the EPA grant that we have, looking at what the air quality and health impacts would be as we turn the fleet over to electric vehicles, is kind of going in the one of the ways that we're trying to get a better understanding of that. But obviously, electrification of particularly heavy-duty vehicles will take time. And I think the city's effort is really making sure that they are, this is why this development of the sensor-based network at hyperlocal scale is really important, because they want to rely on data to catch those who violate their air pollution operating permits, and hold the sources responsible for those violations, have more active enforcement capability and actions. So those are some of the ways that can curtail the burden that you're alluding to. In addition, I think this will involve a lot of transportation planning, a lot of potentially just again, bringing renewable energy sources to the mix, but it is a long-term, certainly, a remediation and revitalization effort on the transportation side.
Thank you. And Eric asks a question, what examples stand out for community-specific knowledge that might not be more widely known throughout the city?
Not sure what it means. I'm not sure of the question.
I think that for me, someone who's done this work, it just is a high spatial variability of exposure concentrations, even in a small neighborhood. So that is something that those of us who've done exposure monitoring didn't really appreciate that much. But when we look at now, we're able to get more microscale exposure data, and we see high variability in exposure concentrations in even a small neighborhood. And so this is why the creation of and maintenance and operation of an air monitoring network at microscale, at least, even if we don't get into hyperlocal scale, is really important so that we can have a better understanding of exposures at the community level. And the study that I showed you from UCLA actually goes one step further, because they have personal exposure monitoring on the subjects. So that is another way to get really kind of individual level data, as opposed to relying on area concentration data. But these tools are improving and increasing our ability to be able to assess exposures at individual and community level better. I think that's what strikes me. I don't know whether Dr. Persky, you have more insight into this question.
I'm not sure I completely understand the question, but with General Iron, the community immediately affected, first on the north side, was aware that metal recycling was a problem that other people might not have known. And then when it moved to the south side, that knowledge carried with them. You know, Dr. Erdal and I were asked by the alderman at the time to monitor around the site, because the community knew that that was the industry that was was causing trouble. And now, as I'm not sure I'm responsive to the question though. And now, you know, when it moved to the south side, the community carried that knowledge with them. And, you know, so far managed to, you know, slow down or maybe even block General Iron functioning. And now that knowledge is being carried over to Sims, which is an already permitted metal recycling plant in Pilsen. But I'm not sure I'm being responsive to the question, but a community immediately affected can then develop knowledge that can help the rest of the city. Is that answering your question? Yes, no?
All right. Yes, it looks like the question was successfully answered.
Okay.
And I did want to ask about General Iron and about Sims, and maybe that's I'll throw that out there, and then if we don't get more questions in the chat, then we can move on to Dr. Miller's presentation. But I wanted to ask you, Dr. Persky, if first of all, I saw General Iron in your presentation, and you didn't talk about it a lot, but I know you've done a lot of work just sort of like understanding what the impact of that metal recycling facility is. So I'd love to hear you talk a little about that. I'd also like to, if you have any knowledge on this, help us understand with something like Sims, which has been permitted, what the community can do to understand the burden, represent it to people who are in charge of policy, and then ultimately to try to affect the permit that's already been granted?
They're good questions. You know, we were asked by Alderman Hopkins several years ago. It came to me, and then I went to Serap to try, you know, the north side's a wealthy community, and people were having trouble breathing, and they felt it was general iron. One community member donated, I think, $10,000, which is very little. So it was a teeny study, and we couldn't get right within the framework. But what, and again, Serap did the monitoring, but she found that the higher levels were closer to the fence, but they were still below the then permit. And I think that the standard, and I think that that's a very good example of why the standard's got to get changed. So we had pushback from the industry, we had pushback from the mayor's office, we had pushback from a lot of people. Well, why are you worried? There's something of a difference, and it was a small study. And I said, look, you should be doing a bigger study, first of all. You know, and then in the last few years, the data has become so much more obvious that there's a risk below that. You know, for other reasons, I'm sure General Iron shut down there, moved to the south side, and the community on the south side, you know, is really terrific. I mean, supported by many of us, you know, hundreds of us, I suspect, around the city and around the country. They were able to stop General Iron given its history so far. It's not clear this is gonna, you know, hold for reopening. And I think whatever knowledge we had, you know, and all the pushes and all the pushback helped. But, you know, our knowledge, we need bigger studies and we need better monitoring, and we didn't have the money or the ability or the you know, the force that the city would have had they actually done the right study on the north side. And I think that's a, you know, continuing over to SIMS. And now I'm not an expert on SIMS. I haven't been part of that. But, you know, I think it's a problem in that you've got to, you know, it's really important, this monitoring business. It's incredibly important. It isn't just science, it is the basis of any advocacy. And if you don't have the monitoring, you can't do the advocacy. And I think it's much harder once the permit's been given. It's incredibly harder to back off from it. You know, I think there's many stages in here, but what I try to emphasize in my talk on, you know, building into SERPs is that if we don't have the right infrastructure in place for the monitoring, then the advocacy groups, you know, can't get it done. You know, our very small pilot study on the north side, I think, was important. You know, it helped the community groups. We had, you know, we had a lot of pushback from industry, a lot.
Well, thank you, Dr. Persky, for sharing all of this. And thank you and Dr. Erdal both for your presentations.